Hey everybody, this is Missy Henke again. I'm the medical director of the Heartbeat Foundation. This is our second presentation, basically an introduction to opioid use disorder, treating it in our community, and the project coming up that we're all going to be working on together. So this one's a little bit more fluff than you guys are probably used to, but still pretty relevant to what we're talking about. So here goes. So we're going to talk about stigma and harm reduction today. Basic outline, we're going to talk about stereotyping, stigma and shame, harm reduction, and then the CA Bridge, which is a great project taking place out in California. So stereotyping, what is it? Well, people judge one another, interpret and evaluate each other's behaviors, find ways to inevitably group people into ready-made categories. We all do this on a regular basis based on simplistic generalizations, and it can be harmless and actually quite useful, because it can become corrupted when those stereotypes become negative. So, for example, you can look at this and make some basic stereotypes, right? They're called fanatics for a reason, right? These are your basic sports fans, but in general, we probably wouldn't have too much negative to say about them, except maybe we don't like their teams. But all in all, we probably wouldn't think too much about walking down the street on the day of a game and seeing someone like this. What about these ones? Well, these ones are a little bit different, right? The stereotype here, I think facial tattoos are just a problem, but junkie, addict, meth head, dope fiend, these are not necessarily benign generalizations and benign stereotypes like fanatic would be, right? So some stereotypical beliefs about addiction. It's a choice. If they wanted to stop, they would. Let them suffer. They made this mess, let them figure it out. Treatment doesn't work anyway. Never seen anyone get better. Drug addicts are criminals. They should all be locked up. I've heard all of these things. I have heard family members say so much as they deserve to die. Just some different thoughts. And again, until it's in your living room, maybe that is how you feel. But fortunately, everyone that comes through my office has been in someone's living room and somebody cares about them. So these stereotypical beliefs are really harmful. It contributes to what we call stigma. And stigma originates from the ancient Greek word meaning tattoo or puncture mark, from the practice of branding slaves with pointed stick. So Goffman in 1963 said that stigma reduces an individual from a whole and usual person to a tainted and discounted one. So again, we're taking somebody who could be productive and useful, and because of our stigma, we're basically discarding them. Oxford says it's a mark of disgrace or infamy, a sign of severe censure or condemnation, regarded as impressed on a person or thing or a brand. We've seen this before, right? An actual brand. How something as simple as a gold star reduces someone to something less than. And so when we talk about stigma associated with addiction, it's not quite as obvious as a tattoo or a gold star, but the idea is the same. Everyone that was living in Europe in the 1930s and 40s that saw that gold star had an idea about who these people were. They were, dangerous, worthless, unpredictable, whatever it might be, but there was an identity that was tied to those things. So public stigma occurs when the general public endorses negative stereotypes and discriminates against a group of people. Again, Nazi Germany is the classic, right? Excludes affected individuals from public engagement by seeing them as unreliable and untrustworthy. So the public stigma of addiction has the tendency to feed into, sustain, or exacerbate the very practices it sets out to approach, right? Like, how come addicts don't get jobs? Well, we'll give them a job, right? And with facial tattoos, there's only a couple places you can probably work. So, but we have this idea that, these people are worthless and they don't take care of their kids. But how do they take care of their kids when they can't get housing and they can't get rent? Yeah, they're homeless with their children, but maybe they're doing all the right things, but because of their record, they can't get into housing. They can't get into a job. And some of that is related to stigma. Public stigma towards individuals who use drugs found that public perceptions of dangerousness, unpredictability, irresponsibility, and blame for their condition were commonly endorsed. Again, why would I give someone a job who has a history of addiction when they're not going to show up anyway, right? That's what happens. They don't show up. Core stereotypes were endorsed, including dangerousness, criminality, hopelessness, worthlessness, and blameworthiness. Again, I'm not going to have them in my apartment complex because they're just going to bring trouble. They're just going to have all those nasty people in and out of their apartments all the time. But then they don't have anywhere to live, right? And they can't get a job. So they do go back to what they know, which is selling drugs and criminality. And again, that stigma that we're talking about forces them to do the very thing that they don't want to do in the first place. So use of substance abuse treatment was actually associated with increased stigma. So imagine you're somebody who finally decides to go to treatment, and then people treat you worse because, oh my gosh, you were so sick, you had to go to treatment. Lifetime substance use treatment was significantly associated with greater internalized stigma. And here's an interesting one. Stigma is especially high amongst healthcare workers toward patients on methadone maintenance therapy. So again, those of us sitting in the medical field, it's like, I don't know how I feel about people on methadone. And I was in that camp when we were first advocating to get opioid treatment programs in the state of North Dakota. I thought it was a great idea. The data is very robust and very supportive of methadone to treat an opioid use disorder. But I didn't want to do it. I didn't want to be a part of it. I didn't think Harvey should do it, right? So we all have our own internal stigmas. And again, when we talk about stigma amongst healthcare workers, before I started prescribing Suboxone, I didn't want to because I said, that's replacement therapy. It's just keeping people sick. It's trading one drug for another. They're not actually going to get on with their life if they're still taking a medication. And again, through the years and through my patients and different exposures, I've gotten to see the flip side of that, which is that, again, because of those dopamine levels, and they're not getting euphoric, they're not engaging those bad behaviors. They're able to do the things that they want to do and be normal, productive, functional adults. And that's really what changed my own stigma. So what about self-stigma? Well, this occurs when people internalize those negative stereotypes and believe them to be true. So again, if people always treat you like you're worthless and a criminal, pretty soon you start to almost feel worthless, feel hopeless, reduce self-esteem, social withdrawal. I don't want to go out in public. People treat me poorly anyway, right? They jump across the other side of the street because they don't want to walk down the road with me. It may motivate people to continue to use in order to forget or reduce the negative feelings. Again, we talk about the pain of addiction, right? Like with withdrawal, the physical pain, but there's also certainly an amount of internalized mental anguish that goes along with being an addict. And so any kind of pain, whether it's emotional pain, physical pain, will be alleviated with substance abuse. So Edwin Lemert in 1951 talked about deviance, and he was really talking about self-stigma. Deviance was when initial act of deviance is followed by the process of a deviant identity. Again, you sort of take on that self-stigma. The deviant act is given a negative label by authority figures. So I always think of like a felon, right? If you're a felon, you're a deviant. If that person accepts this label and becomes part of their identity, like now I'm a negligent parent, now I'm a felon, then that changes how I act and behave. It becomes this self-fulfilling prophecy. And we see this a lot with addiction. So what are the effects of stigma? Well, it can actually be a barrier to help seeking, right? We all say that we want addicts to get better now. We want them to stop using, and we don't want them doing the things that they're doing, right? Because they give our communities a bad reputation, and they endanger our kids, and they do all of these things. We want them to get help, but we don't make it easy, right? And there's increased acting out behaviors, reduced public funding for services. We're all about public funding for breast cancer research and autism and all of these illnesses where people didn't have a choice, right? But we don't want to put public funding towards addiction and mental illness because those people have a choice, right? And again, stigma can contribute to suicidality and shame. Shame is a painful emotion caused by consciousness of guilt, shortcoming, or impropriety, and it is directed towards oneself, compounded by aggregation of guilt. And when you see someone who's been using for 20 years, they've got plenty to feel guilty about. They've stolen, they've lied, they've cheated, they've done all of the things, right? So there's all of this guilt and shame that they have to deal with. And if you've ever talked to someone who's in recovery and working their steps, part of that step is making amends for the things that they've done. And a lot of times they don't even realize all the things that they've done. And again, shame does not need to be related to a shameful behavior. So I was thinking of like when I was in high school and I drove a station wagon. We called it the nation wagon, right? And I was so ashamed of this car. Well, there's nothing wrong with the car, right? It got me from A to B, and the heater worked, the air conditioning worked, it was fine. But again, so shame doesn't necessarily have to be tied to a shameful behavior. But when we're talking about addiction, it really generally is. And it is very counterproductive. leads to a quality of life that undermines the motivation needed to heal. Again, if you hate yourself, how are you going to do the work to change your life? Because you don't feel like you're worth it. So again, it reinforces that drug use in order to blunt or eradicate the negative feelings and attitudes, because I've done horrible things, right? I've neglected my kids. I beat my kids. I stole from my parents. I did all of these horrible things. Oh, I might as well just use, because I'm worthless and I'm dangerous and I'm all of these things anyway. So, and this was an interesting study in the British Journal of Psychiatry. They talked about in areas of the country where shame and self-stigma were low, they had less suicide. Where shame and self-stigma were high, they had high suicides. And suicide rates are also higher where appropriate treatments are lacking, right? Because again, if we don't have treatment, we don't have anything to compound these this ongoing guilt and this ongoing use. We don't have any tools. So the use continues, so the guilt continues, so the shame continues, and ultimately a lot of people in that struggle will end up committing suicide. So what do we know, right? So that's what we know about shame and stigma, but what else do we know? We know that emergency departments have access to people with substance use disorders, right? Not new information. Where do people end up? They end up on your doorstep. There has been an increase in overdose deaths related to opioids, primarily fentanyl, right? That's driving the overdose epidemic. It's driving the opioid epidemic. Studies from Massachusetts found that after an ER visit for opioid overdose, mortality at 12 months was 5.5%. 22% of those deaths occurred in the 48 hours after the ED discharge, right? That's pretty alarming to think that, of those that died, a good percentage of them died within 2 days. Initiation of buprenorphine in the ED prior to discharge increased rates of linkage to outpatient treatment. So if they were started on medication-assisted treatment in the ED, they were more likely to end up in outpatient treatment, right? More likely to get the help that they need. Patients who were admitted to the hospital and started on buprenorphine have increased rates of linkage to outpatient treatment. Again, as we talked about in the first presentation, what buprenorphine and methadone do is they satisfy those receptors so that we don't have the intense cravings and we don't have all of that obsessive thinking, so we can actually engage in doing the things we need to do, like go to treatment, right? If I'm in the hospital and I'm in opioid withdrawal, the act of picking up the phone to call a treatment facility is more than I can even fathom or wrap my head around. All I can think about is getting a hold of heroin to stop how I feel, right? But again, if we can get people started on medications and their brains can actually engage in the task at hand, they're more likely to end up in treatment. 60 to 80% of people who abuse opioids do not have access to buprenorphine. The vast majority of people with an opioid use disorder do not have access to buprenorphine, even though we know medication-assisted treatment improves survival, increases retention and treatment, decreases drug use, decreases hepatitis and HIV, decreases criminal activities, increases employment, improves birth outcomes. There's no downside. And again, if you don't care about people and all you care about is dollar bills, there's a lot of dollar bills saved with medication-assisted treatment, right? So even though we know all of these things, the vast majority of people don't have access to the medications that can change their outcomes. And again, reduction of harm, right? That's what we're going to talk about. Pragmatic it is. So harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. It's nothing magical, right? It's a continuum. It's not a one thing. It's not like, this is harm reduction. Nope. It's all of these things, right? So if someone is overdosing on a regular basis, harm reduction might involve Narcan, right? You just need to have Narcan. The people that love you need to have Narcan. If we're talking about someone who's using very intermittently, but they're using IV, maybe they need clean syringes, right? Harm reduction is a continuum. Cessation of drug use is not a requirement. Again, we're reducing harm. It's not black or white. It's meant to be non-judgmental and non-coercive. So congratulations to drugs for winning the war on drugs. Saying no to drugs doesn't work. Incarcerating people for their addiction does not work. We've learned that over and over and over again. And I mean, even our law enforcement people are saying it's not helping. Incarcerating is not helping. So what are some harm reduction strategies? Well, we know that medication-assisted treatment is a harm reduction strategy. Narcan is a harm reduction strategy, right? I think of Narcan as a seatbelt for addicts, right? So when I talk to people, they go, oh, you know what Narcan does? All that does is make people increase their use. It just makes them push the limits. Okay, so they shouldn't have Narcan then. Okay, but if you're in a car accident and your seatbelt works, are you going to drive faster the next time? Are you going to not wear the seatbelt? No, you're going to wear the seatbelt because it's there to prevent something happening that you didn't intend to happen, right? The vast majority of opioid users don't intend to overdose. Certainly there are some that do, but the vast majority do not intend to overdose. So having naloxone available to them is like having a seatbelt in your car, right? You don't know what's going to happen. So have naloxone because it gives you an opportunity to live another day and maybe get treatment. The only addict that can't come to treatment is a dead addict, right? So they have to stay alive to get in the doors to get well. Medical marijuana is a harm reduction, right? So I have lots of patients who are IV heroin users. They're, extensive history of drug use, and they have their medical card, and they're able to work, and they're able to do some things that they wouldn't otherwise be able to do. Do I love that they use medical marijuana? I don't. Is it harm reduction? 100%. Syringe exchange and safe injection sites. And we don't have safe injection sites here, but we do have a syringe exchange in Mandan. We also have medical marijuana, MAT, and naloxone. So what other harm reduction strategies are there? Well, reducing stigma is harm reduction, right? We talked about how dangerous stigma is and how dangerous shame is, and it leads to suicidality, and it leads to ongoing drug use. So if we can reduce stigma, we can reduce harm, right? So a survey revealed that 75% of primary care physicians were unwilling to have a person with OUD marry into their family. 2/3 viewed people with opioid use disorder as dangerous, right? Just blanket statement, they're dangerous. So if we can use first-person language, okay, not calling them junkies, methods, tweakers, all of those ugly words, right? Like there's first-person language, and I'm not good at this because, again, I still sometimes say people are clean instead of sober, and I say relapse instead of return to use, and I use that language not maliciously, of course, but it's a change in how we do things. And so again, if we can all change how we talk about people, maybe we can change how we feel about people. And again, emphasizing solutions reduces stigma. So part of this grant is offering a solution, right? Someone's in your ED and they've overdosed, or they have an abscess on their arm, or they're pregnant and they're in withdrawal, whatever the case may be. Now you have another tool, right? It's another solution. So when they come in, the idea being that they can get connected to services, because sometimes they don't know what services are out there, or they know, but they don't know how to get in, they don't know how to get insurance, they don't know how to do any of the things, right? So you're going to offer them a solution. We're going to offer them a solution. We're going to work together to get a solution, and that's going to reduce stigma. Because instead of just, just get them out the door, like they're demanding to leave, right? Because they got Narcan, they don't feel good. But if you had something else to offer, that might make a difference for them. And then to create an environment of help seeking rather than drug seeking, right? Again, we want people to know where to go to get help. Like they can come to Heartview and then they're told it's a waiting list of 4 to 6, right? We don't have walk-in services. Human service centers have walk-in services, but then they do their eval and then they can come to treatment in 2 months, right? So we need to create an environment where people understand that their addiction is going to be treated like an illness, and that there are solutions in the community, not just in the ED, in the community as a whole, that we are partnering with various agencies around town to just really wrap our arms around these people and get them the care and the help that they need. So that is the end of our second talk. So to go over some questions. So which of the following statements regarding stigma are true? It motivates people with SUD. It increases public funding. It reduces people with an SUD to feeling discounted. And it helps the general public to better understand addiction. And again, I'm not going to give you the answers on these, but honestly, you guys, if you get these wrong, I don't know. Which of the following are not stereotypes of people with an SUD? Criminality, hopefulness, worthlessness, dangerousness. True or false? Suicide rates are higher when appropriate treatments for SUD are lacking. Last one, identify all of the following that are harm reduction strategies: medication-assisted treatment, medical marijuana, naloxone, and syringe exchange. So that ends our second talk. So the third one is coming shortly, and the third one is really going to go into the nitty-gritty of what this grant looks like, what a day in the life looks like, how we're going to partner, how we're going to communicate, how all of this is going to look. So I appreciate your guys' attention, and have a great day. I'm currently looking outside my window at a blizzard, an ongoing blizzard. So hopefully that is gone by the time you're watching this video. Thanks, guys.